final session, Living Well with Dementia, Lessons for Policy and Practice from Lived Experiences. And what I'd like to do is focus a little bit actually on the living well part of the title there. Commonly in dementia care for older people at the moment, there is a big push and a big driver towards living well with dementia. It's a phrase you'll come across often. And I want us to think a little bit today about how far we support people with a learning disability and dementia to live well. And that's certainly part of what I'd like to come back to as I go through the presentation. So I'd like to give a little bit of an overview to start with, trying very hard not to replicate anything I said in the workshops, because I did promise that I wouldn't. So, and also I'd like to focus on a specific piece of research and just talk a little bit about the methods to include people with a learning disability and dementia in that research, what the implications of the research findings are for policy and practice, and actually finish up thinking out really how far are we supporting people to live well? How can we do this better? So, I don't know how well you can see that from the back there, but just starting with a family photograph, my family photograph actually. Round about 1950, early 1950s, the lady in the middle, Joyce, has Down syndrome. Joyce was the oldest of 9 children. My granddad was the youngest. Little girl front left is my mum. That's all the family stuff done. I won't keep going on about that. But untypical of its time. Great piece of social history, looking at the dresses tucked up here in the sea and the trousers rolled up, and we haven't quite got the knotted hanky on the head, but just about all but. But an extended family holiday, typical of the time, extended family holiday, going away to a local beach, local seaside resort. And Joyce very much in the centre of the family there. And now not necessarily typical of the time, as I say, but Joyce lived to old age. And one of the reasons that might be, perhaps, is quality of life. We talk about quality of life and increased medical intervention as making a difference now. But certainly, I think it was a useful starting point to say, actually, people have been getting older with a learning disability for quite a long time. Not all as successfully as others, but certainly it's maybe not new. But we need to rethink how we're supporting people, certainly with health conditions, as things change. And one of the things that makes it difficult to provide that support and to think about people living well is that the diagnosis is difficult. And it's often not shared. And I'll look at those two things separately. The diagnosis, a typical test for dementia would be the mini mental state examination you've probably come across. I don't know if you've ever seen that or tried it yourself. I didn't get all the questions right. They're not that straightforward, they're quite tricky. So it's not an appropriate test for everybody, for someone who may have found it difficult even before they started experiencing cognitive changes associated with dementia. So not ideal. So what's recommended that most of you will be familiar with is that we have a baseline assessment carried out with people who have, certainly people who have Down syndrome from 30, some places do it, 40 other areas, and that's something we touched on earlier. Because without that baseline assessment, how can we monitor or measure any changes? Or how can we start to think what these changes might be as a result of? And I just wanted to talk about one of the tools that is currently a new tool that has been adapted for use in the UK by myself and colleagues in Scotland. And you might have come across a different range of screening tools for dementia, particularly in people with Down syndrome. The original ones came from the Netherlands. Translation didn't always quite work. But since then, they've got more, been adapted more and more. The D-Squid from West Midlands, you might have come across as well. This tool, the National Task Group Early Detection Screen for Dementia tool, was developed from D-Squid. And we look at, that's the website there. It's what it provides is an opportunity to have a baseline assessment for someone and for someone who knows the person well to be able to monitor changes. But it might not be changes associated with dementia. And that's a really important part, that there are any number of other health conditions that we actually should be looking for as well, to look for treatable conditions rather than going straight in and thinking, well, this must be dementia. And this also allows for a section for where possible for the person to self-report changes that have been noted as well, which isn't always there in some of the other tools that are available. And when you look at the website, it actually looks a little bit odd, perhaps, because you've got English at the top, and then we've done a Scottish version, and that's not just because we like to do things differently in Scotland. I'm not sure if I quite count as an international speaker yet, but maybe watch this space in a few years' time. We'll see how that goes, but not yet. But the reason why we adapted it for use in Scotland is because the English version is actually American. And the language, the terminology, and where to go to next for support is American. So that's the reason why it has been specifically adapted. And that tool, as we have adapted, is also being used in parts of England now as well. So we've just piloted this, and we're about to make our final versions, our final updates to put back on the website. So it's something that you're very welcome to look at, have a look, see how that applies to you, see if that's something that you could use in your practice as well. And one of the things it highlights is that the risk of misdiagnosis, and whether that be for another physical condition, undiagnosed pain, emotional, grief reaction, grief response, social, friendships, or the effects of medication. The images here, those of you who were at the workshops will have spotted already, is a new resource called Jenny's Diary, and there's 1 or 2 copies left outside, I think, if anybody would like to pick up a copy. But also one of the areas that sensory impairment, if you think about the differences, we often talk about people, an early sign that we notice in people with a learning disability is difficulty with thresholds, difficulty stepping between rooms with what might look like a step. If you look at the red carpet over there, moving on to the black carpet, this is really not very dementia friendly in terms of the environment. We've got very grey and grey and grey, and just look around the room you're in or the building you're in, and just get people to really think, actually, how would someone with dementia cope in this environment? And certainly over there is not so good. But equally, if someone has difficulty with their vision, they're also going to have problems with a threshold. They're also going to have problems identifying where the floor ends and the wall starts. If you think about someone who has macular degeneration, which is this bottom left here, if you can't read the text there, someone looking down is actually not going to be able to tell if they're stepping up or down a curb because they're not going to be able to see the curb. They're going to have to turn their head that way when they want to look down here. Whereas someone with glaucoma, you're going to have the opposite. It's the peripheral vision that's going to be really difficult. So if you're approaching someone from the side and even touching someone, you're going to get a reaction. It might not be the reaction you want because the person doesn't know you're there. So all of these things lead to what's called or suspected as changes in behaviour, potentially, but it's to do with eyesight, not to do with dementia. So this is the kind of thing that we need to bear in mind, that this is age-related macular degeneration. This isn't specific to people with a learning disability. So these things are going to be happening for the folk that we're supporting as well. So unless we rule out and test for this, and this is just one example of a sensory impairment, and that's before we even start on ears and anything else as well. So to think about what other things are going on as well, and not make that assumption that actually we might be talking about dementia. So supporting someone to live well is actually having her eyes tested and getting the right prescription glasses, and then wearing the right prescription glasses and not somebody else's, or glasses that are clean. So the kind of things that come across on a day-to-day basis. In terms of including people with a learning disability and dementia in research, we don't do it that often. And part of that reason is because it's not that easy. And people will be marginalised already by other folks' perception of that learning disability. So we've got the learning disability and ageing before we even add dementia as well. And there is a real lack of an evidence base from the perspective of the person with the learning disability, including actually how many people have Down syndrome to start with, which doesn't really help with planning in the medium or long term if we actually don't have that information, and not everywhere does. And we're as guilty in Scotland of that as anywhere else as well. So I just want to talk a little bit about some findings from research that did include people with Down syndrome and dementia. And the first part of that research was with carers, a postal questionnaire to find out awareness, and that gave us access to people with Down syndrome and dementia who took part over a 3-year period. So we could find out from 3 people, small scale, small study, what their experiences were of living with dementia. And the findings from the carers and something that I worked at Down Syndrome Scotland for a long time, and we regularly supported older parents supporting an adult child with Down syndrome, and very much a reciprocal caring arrangement where one or sometimes both generations had a diagnosis of dementia. And that's something that we're coming across more often and is worrying. But certainly indicating that a lack of forward planning, a lack of inclusion of people with Down syndrome in planning ahead. So what we did was over a 3-year period where communication changed, so we had to adapt the communication methods that we used, and also use participant observation with people over a 3-year period. And these 3 people lived in 3 different accommodation settings. So we had Hannah, who lived in a care home for older people. She communicated very, very touchy-feely, very tactile lady. Lucy, who lived in a small group home, and then moved to a slightly larger group home when she had difficulty with the stairs. Her communication was largely pictorial. And Andrew, who continued to live on his own with outreach support. So just a little bit about how these people were, these 3 individuals were living with dementia, and you can decide for yourself if you think they were living well or not. So Hannah had lived with her sister all her life, and her sister was widowed early, so there was the 2 of them until her sister became too ill and went into hospital. And Hannah moved to a care home for older people, where she was significantly younger than the other residents who were in there, and couldn't talk very much when she moved in, but she could still sing. So again, not untypical of people with dementia, different part of the brain that will tells you what words are coming next in the song, as opposed to having a conversation and talking. And if you think, if you play a record over and over again or a CD, you know without thinking what's coming next. And it's that's the part of the brain that keeps that going, whereas the part of the brain that engages in conversation is different. So that's often when you'll hear people can hum or sing a tune or tap a tune longer than they're able to communicate verbally. And Hannah took a really early interest in my handbag. She just ignored me and went straight for my bag. And up came the bag and everything came out. Everything came out, and she touching and feeling everything that was in the bag. Then everything went back in again. And then she would, it was okay to talk to me after the bag. So that's how we built up a relationship, using the handbags and taking bags for her and to her and for her to use and carry around. And this was something that had always been important for Hannah. I was more careful what I put in my bag the next time I went to see her. But that's how we built up our relationship. And the touch was very important for her. So she liked to have you holding and stroking her hand. And you could see her body language visibly relaxing when you just sat and stroked her hand. But because she wasn't able to communicate verbally as clearly as some of the other residents who were there, staff were quite wary. They underestimated. She made noises a lot. They didn't like that. That was, and at one point staff said to me, could she talk when she was a wee girl? And she could talk when she moved into the care home. But people stopped talking to her. So she didn't talk to them. And very much isolated and withdrawn within the care home in terms of her experiences. And staff underestimated what she was still able to do because she didn't have that verbal capacity. Lucy, who was in the small shared group home, initially was communicating verbally. And she recognised me when I first went to see her from the photograph I sent. We had the example this morning as well of the photograph on the information sheet, so that she recognised me when I went to see her. So photographs were important to Lucy, and she liked looking through her family photographs. But she became increasingly non-verbal. So we developed a strategy with pictures. Started using the kind of clip art style to start with that you often see, smiley face, sad face, and that didn't work for Lucy. She just saw the colour. She couldn't actually interpret the expression. And then we tried more of a photographic style, but that didn't work for her either. Because she liked looking at family photographs, she thought she should know who was in these photographs. So that didn't work for her. And actually it was the clip art style of pictures that worked for her, and she was able to use them. And staff picked up on that and were able to use that as well. And Lucy died in the group home where she was living with a very much a planned end of life. So when I saw her just a couple of weeks before she died, and her room, the lighting was quite... She loved Christmas. So this was in March, so she had Christmas in her room in March. So end of life, she had a tree, the lights, everything exactly as she wanted it. And Disney films on constantly, because she loved the Disney music. Very quiet, but really, staff really knew her and listened to her. And Lucy's funeral was completely different to the funeral of other people's with a learning disability that I have been to, because it was so personal to her. And yes, it was Daniel O'Donnell, and yes, it was Elvis, but that's what she wanted. And the photographs were of her and her family, and she chose the photographs and she chose the hymns as well. But the friends who were there from her previous group home hadn't known she was dying. That contact hadn't been maintained when she moved, so it was a real shock for them. And this is where we need more proactive support from staff to actually maintain relationships. It's not always people's choice with how their relationships are supported. Andrew lived on his own. He was having increasing difficulty with word finding, but he was still able to talk and communicate verbally. And because of that, staff were overestimating what he was able to do. So when I first went to see him, it was clear he'd been cooking for himself. You could tell by the smell, the pots, the pans that were being used. Gradually over time, that changed to him opening his freezer and showing me 7 microwave ready meals, all identical. Because when he went shopping, he was getting confused, so he just took 7 of the same thing. And the support that was needed for him wasn't being increased. What was being said was, that's his choice. He's shopping, he's living independently. That's his, and there comes a point where that has to stop. And we need to actually look at how well people are being supported on their own and how far it actually is someone's choice if their cognition is changing. And he loved his mobile phone, very proud of it, forgot to charge it constantly. And that's, again, where support is needed in terms of more proactive support. So all 3 weren't aware of their diagnosis. It hadn't been explained to them. It hadn't been talked to, not even necessarily not using the word dementia, but there hadn't been any explanation for the changes that they were experiencing. But what was evident was that all 3 were experiencing what in dementia research is called sense of self, based on Sabat's work, if you know that. But actually identity, sense of identity, that people were able to relate to me, to themselves. They could show emotion and interact in group settings. But that wasn't always picked up by other people. It really took a little bit of getting to know people before. And we didn't always place emphasis on the importance of friendships and relationships. And often that's something that Jenny's diary looks to address. Staff, particularly in shared accommodation, really wanted people to stay where they were. They'd supported people for a long, long time. And sometimes that was the right thing, but sometimes it wasn't. And that's a conversation that we have to have sometimes as well. Actually, where is going to be best placed for someone as their health needs change? So maybe could be living better. Think about how we're talking about the diagnosis as an ongoing process, not a one-off event. Are we talking about someone being ill, cognitive changes, whether or not we use the word dementia? And revising long-term goals. Still individualised, but actually are we looking more at relationship-centred care than perhaps has been a feature previously? Realistic job roles for staff. When people go into supporting people with a learning disability, it's generally for supporting independence, for maintaining goals, long-term priorities, community living, options, socialising, choice. Absolutely, no issue with any of that. But when someone has dementia, that will change. And so are we recruiting staff with the knowledge and awareness that actually you may be supporting someone to the end of their life? You may be supporting someone with dementia. Do we put that in people's role descriptions? So actually we have an accurate reflection of what the role in that job will be, and then back that up with training from induction onwards. So we're looking at general training and actually some specialist training as well. Because what you don't want is the one staff member who knows about dementia to leave, and then you're starting again the next time. So really needs to be more of a strategy in place, and I know some of your organisations are doing that, but not all. And to actually think about the voice of people with a learning disability and dementia, how we can include that more, not just from a research perspective, but in a service and advocacy perspective as well. And really that the best place to coordinate care for people and services for people with a learning disability and dementia, you're in this room. It's learning disability services who are best placed to coordinate that, rather than older people's services and dementia care. So in terms of supporting people to live well, you really are best placed to do that. So I want to just come towards the end with a checklist. If you take nothing else away from today, think about baseline assessments from age 30. Think about regular and consistent screening after that baseline assessment, along with other routine health checks. Life story work. The people in the study I spoke about who were supported to live well, that happened because staff knew their story and they knew what would support them best. Now that's not always possible and it's not always easy, and sometimes it's trial and error. But if we don't try to find out, then we're not supporting people to live as well as we could be. The realistic staff role profile, go away and check what your local authority or your organisation does in terms of clarity over, because you want the best people to come and want to be there and not get scared when someone gets ill or has a diagnosis of a terminal illness. You want people to maintain that support and understand the supports that can be put in place. The information for staff, families and people with a learning disability, and along with that end-of-life planning to include people in that process. So we have come a long way. I'll finish where I started. We have come a long way since this picture, undoubtedly. Yes, we have more awareness of dementia, but we do have much more awareness of the medical and social interventions that can help people to live better. So what we want is to get to the point where we say that we are supporting people to live well with dementia. And I'll leave it with you to decide if we or your services are actually doing that at the moment. Thank you.